Hello everyone, I hope you're all doing super well. Welcome back. Today we're going to be talking about deep vein thromboses or DVTs and pulmonary embolisms or PEs, and then also touching base on some medications we commonly use and a few things that I've seen come up on exams that can be often a bit tricky to navigate. So before we even start, we obviously are using two different terms, the first being thrombosis, the second being embolism, and I think it's important to just realize the slight difference between the two. So thrombosis refers to the formation of a blood clot within a blood vessel, and this causes occlusion or obstruction at that site, obviously, of the blood flow through the circulatory system. An embolism is just a blockage that may be from anywhere, but then gets dislodged and lodges itself in another place and causes an occlusion there. Now, an embolism can be a thrombus, right? Because a thrombus is just a blood clot. A blood clot that causes an obstruction at the site of formation is a thrombosis in the way we're talking about. But you can also have air emboli, you can also have fat emboli. So that's a slight difference that I think is worthwhile to mention. Next, let's talk about why do we have issues with thrombosis in the first place. So thrombosis or clotting. I'm sure you would have heard of the three predominant groups of risk factors called Virchow's triad, and this is really important and will come up on exams. We know that these three factors are altering one of these three or any of these three can increase your risk of developing clots, but I think it's important to talk about why. Like, why does endothelial injury increase your risk of clotting? Like, what's the mechanism behind that? I think once you understand that, it's really hard to forget. So, blood flow is meant to be nice and smooth and laminar, which means sheet-like. So it's meant to be non-turbulent, right? If, however, there is a damage to the endothelium or your vessels and you are bleeding out, your body naturally should want to stop you from bleeding out, right? But then there's also a balance of, well, you want to prevent bleeding out, but you don't want to clot when you don't have to, because that's also really bad. So how does this work? What's really interesting is that your endothelial layer, the superficial or topmost layer, is coated with anticoagulatory factors, which makes sense, right? Because as blood is flowing nicely and it's only touching the superficial layer, it's okay for it to be anticoagulated slightly because, well, you don't want to clot there, right? However, the layer under the endothelium or the subendothelium, which is almost never in contact with blood normally, right? If you have blood in contact with the subendothelial, you most probably have a damage to the superficial layer, right? And it's pathological, and therefore the subendothelium has procoagulatory factors, particularly the subendothelial collagen binding site, which binds to platelets through the von Willebrand factor, right? As you can see here. So you have this collagen binding site, which binds to one end. You also have the glycoprotein 1b, which binds to an activated platelet. That's how you have primary clot formation. I hope this makes sense so far. So if you have the normal superficial layer, anticoagulant, subendothelial layer, procoagulant. Stasis is the next one, and I'm sure you all have heard that stasis can cause clots, but why? Have you ever been told why? I personally hadn't. And I thought, well, I know that blood's not moving, it can clot, but not really why. So what happens is that in your blood, you have procoagulatory proteases, or these are basically proteins that are procoagulatory, right? Such as thrombin. What happens is that these procoagulatory proteases are always acting on the surrounding anticoagulant pathways. So your procoagulants are always trying to cause a clot. Your antis are always trying to prevent a clot, right? When blood is flowing normally, these proteases often don't have enough time to actually kickstart that clot formation process. However, with normal blood flow, you often don't have an accumulation of these proteases at a high enough level to cause a thrombus formation. However, if you're not moving, you can have an accumulation of proteases or these procoagulant proteases causing thrombosis. Next, we have hypercoagulability. Again, we've talked about that balance between pro and anticoagulants. If you have a rise in procoagulatory substances or a loss in anticoagulatory substances, both of those factors will cause clots. The few important ones you need to know that can be disrupted are factors 7, that's 7, 8, and 1 Willebrand factor. But if you also lose things like protein C, protein S, and antithrombin, that can also lead to a hypercoagulable state. One thing that I'll mention here is nephrotic syndrome, the one with your kidneys, where you lose tons of proteins, right? The most common one you would lose is albumin, because it's the most commonly found protein in your body. But along with albumin, you also lose protein C, protein S, and antithrombin. And the loss of these proteins actually puts you at a hypercoagulable state, which is why individuals with long-term nephrotic syndrome are at a significantly higher risk of developing clots. That's an important side note there. Cancers are also a huge risk factor for clots because of the same hypercoagulability phenomenon. Why does this happen? Well, firstly, tumors, which are obviously abnormal growths and lumps of cells, they contain, their surface membranes contain these procoagulatory tissues, right? And when the tumors do shed, and that's something that happens when you have tons of growth, some of the membrane will actually shed. And when they do shed, it can lead to procoagulatory activity. Tumors also cause inflammation. And as you would know, inflammation often goes hand in hand with the increase in the release of procoagulatory factors. Cancers can also disrupt lymphatic and venous circulation by compressing them or by causing edema, and this can again lead to stasis, again causing increased clotting risk. So here's a summary of Virchow's triad. I've added what the most kind of common diseases or presentations that go hand in hand with each one of the triads. So trauma, surgery, I'll let you read through this, but it's always good to ask risk factors for these. So things like obesity, recent surgery, immobility, flights, medications like the OCP, if they have any cancers, smoking, thrombophilia, all of these basically increase your risk of clots. And this is a really good page for OSCEs in particular. Now let's start with DVTs. So what are DVTs? So DVTs are a clot in your deep veins. So that's important to mention, right? Because you can have superficial venous thrombosis, but that's not the one we're talking about. We're talking about deep venous thrombosis. It's common-ish, 1.6 new cases per 1,000. When you get to fifth year, you'll pretty certainly see one of these in ED at some point. So what are the clinical features? So swelling, because if you have a clot, let's say you have a clot somewhere here, you're going to obstruct venous flow, going to cause swelling. Also going to cause warmth and redness because of, again, the blood just being pulled in. You can have tenderness and pain that's progressively worsening. And that can be partly hand in hand with ischemia as well. And then you can have distension of the superficial veins. Now, how does this work? Well, in your legs, you have two venous systems, or you have a deep venous system and a superficial venous system. And both of these work together to deviate blood flow from your peripheries moving centrally, just return venous flow, right? What often happens is that your superficial veins collect the blood and drain them into the deep veins. However, if this is not possible because your deep vein is obstructed, you will have increased blood flow in the superficial veins, and that's quite a distinct sign. You can also have a few other signs in particular. So we have Homan sign, which is calf pain on dorsiflexion of the foot. So if you dorsiflex or push your foot up, basically, you can have calf pain. And that is because you are causing a stretch and further irritation of the venous system. You can have the Mayer sign, and this is the most commonly used one, probably. Compression of the calf itself causes pain. And the Payer sign, which is pain on applying pressure on the medial sole of the foot. I actually don't know why this is the case, but I'm sure there's some pathophysiological basis behind that. And always, 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 if you suspect a DVT, please ask for PE, because if you have a clot that originates here, it is very possible for it to embolize further and go into your lungs. And so ask about things like dyspnea, pleuritic chest pain. Now, the investigations you order if you suspect a DVT really depend on how likely you think a DVT is. If you think that a DVT is pretty likely, order an ultrasound, because that's the investigation of choice for DVTs. Some features that would indicate or would point you towards a DVT would be non-compressible veins. Why? Because if you have a clot right above, you have obviously pooling of blood, and the pooling of the blood causes increased pressure, which makes it non-compressible when you press it with a probe. You can see a thrombus in some cases. You lose phasic venous flow. So the venous flow bit is obvious, but what does phasic mean? Phasic, basically, the venous flow, even in the deep veins, tends to be pulsatile to a degree, so you lose that with DVTs. And then increased flow in superficial veins, which you can actually measure, which again goes back to the same principle of the distension in the superficial veins, because you can't drain blood through the deep venous system. If you, however, think a DVT is unlikely, but you still want to do a test to rule it out, you order a D-dimer because it is extremely sensitive. Now, the D-dimer is a very controversial test. The reason why is because although it has a really high sensitivity, which means if you don't have a positive D-dimer, it is very, very, very unlikely for you to have a DVT. But a positive D-dimer often doesn't mean much either. So it's a really sensitive sign, which means if you have a DVT, you will almost always have an increased D-dimer, but the D-dimer increase itself can be because of a lot of other things, which is why it's non-specific. So it's sensitive, but not specific. But then I've talked about, is it pretty likely, not likely, but how do you actually measure this likeliness? And that's done through something called the Wells score for DVTs. Now, don't be confused. There are two Wells score, kind of easy to remember. They go both hand in hand. So one's for DVTs, the other is for PEs. And both of them are used to assess the pretest probability for these conditions. So here is the score. So I'm not going to read it out because I don't think you need that. But a Wells score. What's confusing about the score, and I only learned this when I was in ED, is that a low score is 0 for this, right? So if your patient has any of these, then they are at a moderately increased risk, and I think 3 and above is a high risk. So unless they have no clinical features, which means they are 0 for all of this, they technically don't qualify for a low score, which is slightly confusing to me. So technically, if a patient has any of these positive symptoms, they technically should be getting a Doppler ultrasound. Now, the treatment. Firstly, the treatment depends on a few things. Is this an isolated DVT or a recurrent? So have they had DVTs in the past? Do they have an active cancer? And what is their bleeding risk? If this is a low risk DVT, that's a pretest score. So low risk basically means that they have no severe risk factors for DVTs. They are hemodynamically stable, and they don't look too unwell. You can manage this expectantly, which means you do nothing and you just do serial Doppler ultrasounds, and you let the body resolve it naturally through the production of its own anticoagulant factors. Most patients, however, will not apply in this group. They would at least have a moderate risk PE or a DVT or a recurrent DVT, something or the other, which makes the need to commence some form of therapy ever more relevant. So what you can do, so you would mostly start them on anticoagulation for the first 5 to 10 days. This is usually with enoxaparin or clexane or low molecular weight heparin. And then you would start them on DOACs or warfarin for 3 to 6 months, again, depending on how high risk they are for a future DVT. So let's start with just a simple example. So you have a patient who is completely well, and they've had a DVT, and their risk is their first DVT. They've never had one before, no active cancers. Then you would start them on clexane for about 5 to 10 days, and you would then consider a DOACs, but this probably wouldn't be for too long. Versus someone who is obese, smoker, OCP, cancer, you would consider that for a prolonged period of time because you know the risk of a further DVT is pretty high. Next, we have PEs, right? So PEs, again, it's a blockage of one of the pulmonary arteries due to a venous thrombus. you can be presenting with a wide range of symptoms. So you can be completely asymptomatic to you can present with hemodynamic shock, which is why it's really important to look out for PEs in a wide range of clinical scenarios, including patients who you may suspect have a DVT. Clinical features include dyspnea, pleuritic chest pain, coughing, hemoptysis, tachycardia, and hypotension. The last two are often indicators of severe presentations, and they may escalate to shock really quickly. You also want to look for a source, like, so where did the clot actually come from? So look for things like unilateral leg swelling, calf tenderness, and erythema, because they might have a DVT that's led to a PE. Now, one thing I want to touch on is the actual pleuritic chest pain. Why do they get pleuritic chest pain? And this is a question I found myself asking myself. That makes sense? Me asking myself. Anyway, so you have a blockage in the artery, which is the most common answer that I get when I ask 30-year students, why do you think it causes pleuritic chest pain? But, well, you have a blockage in the artery, but why should that cause pain? Arteries don't have nerve endings and pain receptors. And why is it pleuritic? Some say, oh, Karan, you can have a pleural effusion sometimes, or you could just be pleurisy. And well, in some cases, I agree, you can have a pleural effusion with a PE, but that's not always the case, right? So why do you have pleuritic chest pain, and why is it pleuritic? So the answer to that is that one of the first branches, so your blood goes from your heart to the lungs, to the pulmonary arteries, and then goes back to the heart through the pulmonary veins, right? One of the first branches that actually supplies the pleura comes off that junction between the pulmonary arteries and the pulmonary veins. What this means is that when you have an obstruction at the pulmonary arteries, one of the first areas that is actually undergoing ischemia is your pleura, which is why you get pleuritic chest pain. Correct, because the pleura is inflamed, but this is because of ischemia, not because of the actual thrombus causing irritation. So again, with investigations, you want to basically assess how likely you think a PE is based on this pretest probability. But then there are some other tests that you always want to consider in the acute setting. Remember, these are patients who present with things like shortness of breath and chest pain. You always want to assess for hypoxic status. You could do an ABG, look for acid-base disorders. You often have a stock standard panel of FBE, UECs, LFTs, and QAG studies. QAG study is also important if the patient becomes unstable or they have a massive PE, and you want to consider thrombolysis. You want to make sure that they aren't at a very high INR, for example. TROPS, because, well, patients with shortness of breath and chest pain, you want to rule out an ischemic heart event. ECGs, again, to rule out an acute myocardial infarction, but you can also see the following changes on a PE. So you can see right heart strain. Why do you see changes of right heart strain? And what does that even mean? Like, what is right heart strain on an ECG? So what's happening is you have blockage of the pulmonary artery. That's going to cause backflow of blood into the right-sided heart. And that makes it harder for the heart to deal with, right? So it's because it's pumping against a blockage, which is why you often have signs of right heart strain. Now, what can this be, or what can this look like? You can have T-wave inversion, often in the right-sided heart. You can also have things like right ventricular hypertrophy for someone who may have had past events or has some degree of blockage that is kind of long-term, so long-term PEs. But the other thing that you often hear about is S1QT-T3, and that is the change that is seen with right heart strain. So it's basically a right heart strain pattern, most commonly presenting with PEs, but other kind of pathologies that affect the right heart causing strain in a similar manner can have the same change. So what is S1QT-T3? So you have a predominant S wave in lead 1, you have deep Q waves in lead 3, and you have inverted T waves in lead 3 as well. You can do a chest X-ray because the patient has shortness of breath and chest pain for things like a pneumothorax, aortic dissections, and pleurisy. There are also some other changes that can be seen with PEs on a chest X-ray, but very rarely would you see them. The first one's called a Hampton's hump, which is basically this wedge-shaped area indicating pulmonary ischemia. Atelectasis, so an actual collapse that has to do partly with poor oxygenation and also pleural ischemia, and then pleural effusions because you have backflow of blood that can cause increased hydrostatic pressures, and that can cause pleural effusions. You can also do a Doppler ultrasound of the lower limbs if you suspect a DVT. There are two other investigations that are particularly relevant for PEs, and it's very common for you to be asked about them in exams. And I want you to know the differences really well. So the first one is a D-dimer, where we've already talked about that. But the two other ones are a CTPA or a VQ mismatch study. Now, the choice on whether you want to do imaging of some sort, so CTPA or VQ versus a D-dimer, depends, again, on your pretest probability. Again, there is a Wells score for PEs, and if they're low risk, you can give them a D-dimer, high risk warrants an imaging study. We already talked about that, right? And so the Wells score is based on the exact same principle. We'll talk about that Wells score in a quick second. But what is a CTPA and how is that different to a VQ mismatch study? Something that's really, really important. So please pay super high attention to this page. It is really important, please. So CTPA is a CT pulmonary angiography. Basically, what we do is we pump you with dye or contrast, and it basically enters the pulmonary arteries and lights up where it is, right? So if you have a blockage, the dye won't be able to enter there. It would be everywhere but there, and that can show up on this imaging study. So that would be something like an infraluminal filling defect. So here you have contrast, oh, no contrast. So it has failed to fill intralumen, so in the lumen itself, and this would suggest an obstruction. You can also, because this is a CT, you can very much look at the lung tissue itself, and you can see things like the Hampton's hump equivalent, so wedge-shaped infarcts, but you can also see pleural effusions. One of the most common questions you will be asked on exams and in OSCEs is when to use a CTPA, when to use a VQ mismatch study. Now, the rule of thumb is that CTPAs are almost always better. If you can use a CTPA, use a CTPA. There are three reasons why you wouldn't use a CTPA. If the patient is super well, you don't even think they need any investigation, low risk, well, you can do a D-dimer. But the two reasons why you would use a VQ scan over a CTPA is, firstly, if we can't give them contrast, which is an eGFR less than 30, or if they have allergies to the contrast. Some hospitals say 15 is the threshold, but usually less than 30 is kind of that gray area where we don't really want to be giving them more contrast because it will further affect their kidneys. If their eGFR is between 30 to 45, we usually hydrate them really well, so pre-scan hydration. So give them a lot of fluids to make sure that their kidneys can handle the contrast when we do give it. Alternatively, if we can't give them radiation for some other reason, like if they are pregnant and we don't want to expose them to radiation, and they are clinically well to wait for a VQ scan, then that is the other indication. Now, the Wells score for PEs is 0 to 2 is low risk, 2 to 6 is moderate, 6.5 and above is a high risk score. So these are, again, the factors. I don't think I need to go through these, relatively self-explanatory. So just remember, Wells score for PEs, Wells score for DVTs. When it comes to treatment, again, depends on a few factors, and I know that's not helpful, but I'll try my absolute best to make this as digestible as possible. First question you need to ask yourself, is the patient stable or unstable? So can they respond? Are they hypoxic? Are they tachycardic? Are they hypotensive? Right, all those. If the patient is unstable, you forget everything else, doctors A, B, C, D, and start advanced life support if the patient is pulseless, right? If the patient is hemodynamically unstable, but they are, so they're not pulseless, but they are hemodynamically stable, it is very important to give them an IV fluid bolus, oxygen supplementation, and pain management because chest pain, but also morphine can help with the vasoconstriction as well. Next, so those are the unstable scenarios. So next we have a patient who is stable, so they aren't collapsing, they're not hypotensive, not tachycardic. They can be a bit tachycardic, but they're otherwise fine, they're stable. You want to start them on empirical anticoagulation, which is going to be your low molecular weight heparin or enoxaparin or clexane, right? You can use unfractionated or high molecular weight heparin for unstable patients, or if their eGFR is less than 30, right? What is the difference between those two? We'll get to that in a quick second, but remember, low molecular weight heparin is your go-to. If the patient does not have a massive P after your CTPA or VQ scan, you just do the following stuff. So you want to make sure that they're well hydrated. You want to make sure oxygen supplementation, pain medications, low molecular weight heparin. That's your go-to, right? If the patient does have a massive P, which means that it's quite significant in size, there's often a radiological distinction to make. You want something specific for, so you want definitive therapy that's a bit more than just clexane, right? If the next question, if they have a massive P, is ask yourself, what is their bleeding risk? If low risk, thrombolysis or through tissue plasminogen activator. If they have a high bleeding risk, we don't want to thrombolize them because they will have a bleed. So we use a catheter-guided thrombolytic therapy. Why do we do that? Because if they have a high bleeding risk, we want to make sure that we're only giving the thrombolysis therapy specifically in the lungs where the clot is and not everywhere that can lead to systemic bleeding issues. If the above fails, you then proceed to a clot retrieval or embolectomy. So let's start from the very top very quickly. Patient has a PE. If they're unstable and pulseless, doctors ABC, ALS. If they're unstable but they have a pulse, you want to start them on oxygen supplementation, pain management, and unfractionated or high molecular weight heparin. Remember? Right. If the patient is stable, has a pulse, can speak, all of that, you will start them on low molecular weight heparin, and then you ask yourself, do they have a massive PE? If they don't have massive PE, leave it at that. If they have massive PE, again, you would make sure that you have started them on oxygen, pain meds, clexane, and if they have a low bleeding risk, you go for thrombolysis with TPA. If high bleeding risk, catheter-guided thrombolectomy, thrombolytic therapy. If everything else fails, embolectomy. Sorry if that was confusing. Have a read through. I'm sure it makes sense. Now, next 5 minutes is very quickly talking about some medications that go hand in hand with clots. First, we have warfarin. How does warfarin and what does warfarin do? So warfarin basically affects vitamin C. Vitamin K, sorry. Vitamin K is a cofactor that is useful for the synthesis of factors 2, 7, 9, and 10. The way I was told in second year was the TV channel thing, but that doesn't apply to me because I didn't grow up here, so really an abstract idea to me. But yeah, just 2, 7, 9, 10. So it's like 10. Never mind. I don't have. Just remember it. 2, 7, 9, 10. Most of it is going to be the extrinsic pathway, which is why the PT or the INR is affected. Now, the difference between the PT and the INR is one that I've talked about in another video, but a PT is just a numerical time that's given by a lab, and an INR is basically a ratio. So a PT can be quite different from lab to lab based on what enzymes they particularly use. But an INR is the ratio of how quickly they bled compared to a standard set by that particular lab. So it's basically a standardization tool. You don't need to know PT, just know INR. So INR of 2 means that the patient takes twice as long to clot through the PT pathway as a normal patient would. Factor 7 has the shortest half-life, and therefore the effect is greatest on the extrinsic pathway and not the intrinsic. Oops, sorry. Yes. Yeah, this is not that important. So when we do start someone on warfarin, let's say because they have a higher triad score and they have AF, we want to aim for a warfarin of 2.5. Sorry, that's not 2 to 5. Aim for an INR of 2.5. So 1.5 to 2.5 usually. If they have a mechanical heart valve, you aim for 2.5 to 3.5 because they have a higher risk of clots. Don't use antibiotics with warfarin because both of them use the enzyme cytochrome P450. Yeah, CYP450. And antibiotics also kill gut microflora, which is required for vitamin K absorption. So if you're giving someone an antibiotic, they are not going to absorb vitamin K as well, which means they're already not going to be able to synthesize a lot of these factors as well. You add warfarin on top of that, you're going to throw them into a supratherapeutic INR. Warfarin is given orally and has to be monitored closely via INR, which is why it's a bit of a pain compared to DOACs, which don't have to be monitored. Heparin. So heparin binds to antithrombin. So factor 10 and factor 2. Okay, sorry. Factor 10 and factor 2. There are two forms of heparin. You can either have unfractionated heparin or low molecular weight heparin. The one you'd most commonly use in hospitals is your low molecular weight heparin. So enoxaparin, apixaban, they are all low molecular weight heparins, and they only inhibit factor 10 versus unfractionated heparin, which inhibits both factors 10 and factors 2. The reason we use low molecular weight heparin over unfractionated in most cases is because it's a bit more easy to dose for, and the variations in the effect it generates aren't as much because it only inhibits one thing versus unfractionated, which inhibits two and therefore is more unpredictable. A good way to remember that is both enoxaparin and apixaban, which are the two most commonly used low molecular weight heparins. Both have X. The Roman numeral is 10, so it only inhibits factor 10. This unfractionated, which is both. The two reasons you would give someone unfractionated heparin is if they have, so in the context of PE, again, if they're unstable, and if they have an eGFR less than 30 would be the other indication to use unfractionated over low molecular weight heparin. Thank you all for your attention. Sorry if that went a bit over time. If you have any questions, feel free to get in touch either on email or through Facebook. I'll be more than happy to answer your questions. Please look after yourself and please look after your loved ones, and I will hopefully see you in the next one.